To those of you that have just joined, can you hear me okay? I think you can write in the chat. Fab. We'll probably wait till about like 7:05 to give people a chance to join. Just out of curiosity, so I'm screen sharing on my Mac. On the screen that you can see, can you just see the PowerPoint or can you see like the icon bar across the bottom? Because otherwise that would be really annoying for you. Let me try and sort it out. Oh. Okay, guys. So welcome to this week's Thursday 15 session. Well done to those of you who also went to the one on Tuesday, the Ashgaran. That's good dedication. Today's will be all about geriatrics and palliative care. So what I've tried to do in this session is kind of focus more on specifics of the topics rather than trying to give an explanation of absolutely everything to do with that topic. So in the notes section under the slides, there's quite a lot of information there about extra bits. So make sure that you fill in the feedback form so that you get access to the slides at the end of the session, and you can read all those extra bits. So to those of you who haven't been before, how this normally works is at the beginning, we do about a 15-minute run through. So 1 minute per MCQ as a sort of mock exam, and then we go through all the answers. So if you've got a pen and paper ready, we can start now with the first few questions. So I'll have a timer going and I'll let you know when I'm moving on to the next question. But here we go with question 1. Okay, question 2. Question 3. Question 4. Okay, question 5. Question 6. Question 7. Question 8. Question 9. Question 10. Question 11. Question 12. Question 13. Question 14. And finally, question 15. Okay, so that's us gone through all the questions now, so we'll go on to the explanations. So for those of you that have just joined, my name's Katie. I'm an F1 working in Bristol at the moment, and this session is all about Gerries and palliative care. I know must be getting near your exams now, so well done for joining. I know your time's really precious at this time of year. So what I've tried to do with the explanations and answers is keep them quite focused to specific parts of presentations rather than trying to cover the whole presentation with things that you may have already had covered and already know. I've tried to keep it focused on specific things, but as I said earlier, in the notes underneath the PowerPoint, there's lots and lots of extra information. So make sure you fill out the feedback form. We'll send the link for it in the chat. You'll get the whole PowerPoint and the recording. So you'll be able to access all those extra bits as well in time for your exam. So just moving on quickly to the first question. So this question was about a lady who has end-stage COPD and has recently been started on morphine for breathlessness. She's finding it beneficial, but is having some nausea. So her past medical history is significant for epilepsy, diabetes, and long QTC. So I'll just do the poll and you guys can tell me what you put. Okay, we'll stop it there. So most of you went for the correct answer, which was E. Well done. So cyclizine is the right answer for this question. So I'll just go through why. So lorazepam can be used to treat some types of anticipatory nausea. So you might get questions where they're asking you about a patient having chemotherapy who's feeling nauseous on arrival to the chemo unit. And that's an example of anticipatory nausea, and you can use benzos to try and help manage that. Metoclopramide, that is a good antiemetic, but it is contraindicated in epilepsy. So that's an important one to remember. Because it lowers the seizure threshold, and this lady has epilepsy, so that one's incorrect. C is haloperidol, which is a good antiemetic to use for like opiate related nausea, but this patient has a known long QTC, which means it's contraindicated. And ondansetron as well is not ideal in long QTC, so we tend to try and avoid it. Cyclizine is the correct answer. It's not contraindicated and it's very good at treating kind of toxic nausea. So just in the chat, which arrhythmia do we know that can be precipitated by long QTC? Just like fire out the answer if you know it. So if we gave this lady haloperidol, what arrhythmia might we precipitate? Yeah, exactly. Torsades. Well done, everyone. So that looks like this. It's an example of torsades. So it's a good one to commit to memory because they like asking about it in exams. So with nausea and antiemetics, it's quite helpful to think about what the nausea is coming from and why it's happening. So there's multiple neuropathways involved with nausea and vomiting. You have multiple centers in your brain that are associated with nausea and vomiting. And your emetic response is like mediated by different neurotransmitters, so things like dopamine, serotonin, histamine, acetylcholine, and neurokinin. So lots of the antiemetics work on those neurotransmitters. So you can group the causes of nausea into these kind of four main areas, and you've got a good catch-all of what's causing it. So cerebral causes are generally brain tumours and METs, so raised intracranial pressure, but also radiotherapy, and then the anticipatory or anxiety-related nausea comes under cerebral as well. So with raised ICP, we'll try and lower the pressure in the brain with dexamethasone to shrink things down, reduce the edema in the brain. That can help nausea. And cyclizine and ondansetron are used a lot in radiotherapy. With toxic nausea, that what we're referring to there is kind of lots and lots of nausea and then small and frequent vomits. That's generally how people describe this type of nausea, and the vomiting doesn't tend to relieve the nausea itself. And this is often related to drugs. So like in this question, the opioids and the chemotherapy can trigger nausea, and they're well treated with the generic ondansetron, haloperidol, cyclizine, metoclopramide, all really good at treating drug-related nausea. And then other toxic examples of nausea are things like liver failure, because of the bilirubin can make people feel sick. Renal failure, uremia makes people feel sick. Having a high calcium makes people nauseous, and different infections, particularly UTIs. So haloperidol, levomiprazole are really good for things like that. Gastric causes, so generally these patients are the opposite of toxic. So they have minimal nausea, but they have infrequent large vomits, which do help the nausea. I've just seen someone wants the feedback form in the chat, so just let me copy and paste it, and then you'll all have it there. To everyone. There you go. So in terms of the gastric nausea, like I was saying, minimal nausea and then infrequent large vomits, which help relieve it. So gastric stasis can be caused by things like liver mets, ascites, gastric cancer, gastric outlet obstruction, and different medications can slow your gastric transit. That's quite well treated with ondansetron. Or things that stimulate movement out. If there's no absolute obstruction, you can use things like metoclopramide, which is a prokinetic. But if we know that there's absolute bowel obstruction, then we wouldn't use that, obviously. So bowel obstruction can be treated well with haloperidol, cyclizine, and hyoscine. And then nausea caused by kind of esophagitis, you can just manage well with a PPI. That's generally caused by radiotherapy or using NSAIDs. Vestibular nausea, that's nausea that's described as worse on movement, so that can be like BPPV, labyrinthitis, Meniere's, and then we use the antihistamines for that, so promethazine, but cyclizine is also really good, so good that I've written it twice. Look at that. Some other top tips for being an F1 and managing patient with nausea: just make sure you assess all causes because it could be multifactorial. And remember that medications cause nausea. So if we can trim down any elderly, particularly elderly patients' medications, that's always a good thing. Make sure you're prescribing antiemetics regularly, as well as a second line PRN. Oral routes may be ineffective if the patient's vomiting. So think about subcut or IV antiemetics. Ondansetron and cyclizine are really easy to give IV because the dose conversion is the same. I think like prochlorperazine you can give IM and stuff like that, so there's lots of different routes we can use. You need to make sure that we're considering disease specific precautions, so particularly Parkinson's, we're not going to give haloperidol. The QTC, we're not going to give things that prolong the QTC. Why not metoclopramide in gastric stasis? So I was saying you can give it in gastric stasis, it will help move it along, but if there's something like an absolute gastric outlet obstruction, like a tumour or a thickening, we wouldn't use metoclopramide then, because you wouldn't really be improving the gastric stasis, you'd just be making it crampy. So you need to also consider your interactions. So cyclizine interacts with other kind of antimuscarinic drugs that block the common pathway, which metoclopramide acts through. So using metoclopramide and cyclizine together isn't always a great thing to do, but these things are just extra considerations. The main things are make sure that you're using the right drug that's going to treat the right type of nausea. So some key side effects to remember: the dopamine antagonists, so metoclopramide and domperidone, can cause diarrhea, and they can also cause extrapyramidal side effects. So your classic kind of pseudo-Parkinsonism stuff with the shuffling gait, bradykinesia. They can also cause like acute dystonias and akathisia, so that restlessness. They're also associated with long QT and arrhythmias. And remember with the difference between metoclopramide and domperidone. So metoclopramide we don't use in Parkinson's because it crosses the blood-brain barrier, but domperidone, even though it's dopamine related, you can use that in Parkinson's disease because it doesn't cross the blood-brain barrier. Serotonin antagonists, so that's ondansetron, are commonly associated with constipation, and antihistamine antiemetics, so cyclizine, promethazine, they can be quite sedating, sometimes cause anticholinergic side effects as well. So just consider when people are on those meds whether we'd be increasing an elderly patient's anticholinergic burden if we're adding in these antiemetics. So question 2, this was a question about Parkinson's disease. I will start the poll for that one. There you go. So is that working? I don't know if I've done it. There we go. Can you see that? Fab. Okay, so this was quite a hard question, to be fair. So people have got a bit mixed. Most people have gone for E, and then a couple for A and a couple for B. So bear with me on this. I'm sorry in advance, but I thought it would be kind of, most questions go over like Parkinson's symptoms, and I thought it might help to go over some of the neuroanatomy with this question rather than just going over symptoms and features which you all really already know. So the answer to this question was actually A, because it was which of the following statements is false. So I'll go through the answers with you. So A was false because Parkinson's results from the loss of dopamine neurons within the substantia nigra. So super picky, but it's just kind of like the question's trying to test your knowledge of the neuroanatomy. Oh, you know that. I'll shut my window in a minute. Sorry if that's really annoying. Test your knowledge of the neuroanatomy involved with the basal ganglia and the thalamus. So B is true. Levodopa is the most effective treatment for Parkinson's. Obviously, C is true if estinating gait is classical. Domperidone is a safe antiemetic to use, as we just said, and surgery can be used to improve symptoms. So things like deep brain stimulation and basal ganglia surgery can be used in some cases. So that was true as well. So this, please don't hate me, but I thought it might be quite useful to just go over the neuroanatomy. So this is a really nice diagram of all of the areas that are involved in the basal ganglia. The basal ganglia is an area of the brain, collection of cell bodies in your deep white matter that is implicated in Parkinson's disease. So the areas are pointed out on the diagram nicely in purple and pink. The blue areas in the middle, kind of medially with the red dot on, that's the thalamus. So that's not in the basal ganglia, it's just the pinky purple ones. And so your basal ganglia coordinates our habitual and voluntary movements, either by initiating that or inhibiting it. And it's made up of your caudate, nucleus, your putamen, your globus pallidus, and your substantia nigra. And losing your dopamine neurons in the substantia nigra is what causes the Parkinson's symptoms. So that's the area that's implicated. That's the one to remember. The thalamus isn't part of your basal ganglia, but it has lots of connections to it, and then to the motor cortex. So it relays the motor signals from your basal ganglia to your motor cortex to allow initiation or inhibition of movement. So the pathophys of Parkinson's disease is complicated, and I've tried to really simplify it down. And we'll go through it briefly, and then I'll give you the takeaway basically. So there's two pathways between your basal ganglia, i.e. the pinky purple bits, and the thalamus, the blue bit. One pathway is the direct pathway, and one pathway is the indirect pathway. So the dopamine from the substantia nigra activates or stimulates the direct pathway via D1 receptors, i.e. dopamine 1 receptors. So if you think there's loss of dopamine in the substantia nigra in Parkinson's, then you'll have less stimulation of this direct pathway. So then you'll have less initiation of movement. So the direct pathway stimulates movement. If we're stimulating that less, we'll have less stimulation of movement. The indirect pathway is where it gets a bit messes with your head. So the indirect pathway, the dopamine from the substantia nigra inhibits this pathway via D2 receptors. So, and it's an inhibitory pathway that inhibits movement. So in healthy brains, the substantia nigra is inhibiting this inhibitory pathway, i.e. it's allowing movement generation. Okay, does that make sense? So if there's less dopamine from the substantia nigra in Parkinson's disease, then you get less inhibition of your inhibitory pathway, i.e. you get more inhibition of movement. So combining the two, if there's less dopamine, there's less initiation of movement. And if there's less dopamine, there's more inhibition of movement. That's what causes the symptoms, the classic bradykinesia, the tremor, and the rigidity. If that doesn't make sense, I can say it again. So just put it in the chat if you want me to kind of repeat that more clearly. But hopefully the main takeaway for the purposes of your exam, just be aware that a loss of dopamine in the substantia nigra has an impact on the two main pathways between the basal ganglia and the thalamus that overall make it difficult to initiate purposeful movement for people with Parkinson's disease. So they lead to kind of loss of inhibition of muscular tone, so you get that rigidity and the tremor. And they lead to loss of inhibition of random movement, so the tremor, and they also lead you to slow up. So I hope that makes sense. Please just jump in if it doesn't make any sense at all. Did anyone want to go over particularly the features of Parkinson's disease? Because we can rattle some off together now. But if you're happy that you're happy with them, then we don't have to. Anyone have any strong opinions either way? Yeah, you want to go over them? Okay. Happy to skip. That's hard. Okay, we'll do a couple really quickly. So the three main ones, someone just put the three main Parkinson symptoms in the chat. Bradykinesia, yeah. Rigidity, yeah. Tremor, yes. That's the triad. Bradykinesia is a slowing of your voluntary movements. So you'll see them walk with a reduced arm swing. The tremor is like the classic pill rolling tremor, and the rigidity is a resistance to passive movement. So you get that lead piping of the arm and the cogwheel rigidity. Other things that are common in Parkinson's disease are things like an expressionless face, a soft voice, dribbling. Yeah, great. Motor symptoms, autonomic symptoms, sleep symptoms, and neuropsychiatric symptoms. So there's the gait, the classic shuffling gait that we've talked about a couple of times. People can have mood symptoms, so depression. Bowel and bladder are the common autonomic symptoms. So people get lower urinary tract symptoms, incontinence, constipation, and sleep disorders as well. So hopefully that scratches that itch a bit. So just going on to the management. So generally, the management of Parkinson's disease is an MDT approach. It's not just like Parkinson's, here's the drugs, go and sort it out. It's like there's OT involvement, there's physio involvement, there's dietitians, there's psychiatrists, and there's like movement specialists, geriatricians, sometimes neurologists. So it's really, really complex disease. It's really hard to manage, but it's a big team essentially. There's different types of management. So symptom management is separate to this drug management here. So the symptoms you might treat with things like laxatives or a catheter for the autonomic symptoms. You might treat with something like modafinil in some cases to improve concentration, and antidepressants can be used as well. But you've got to be careful that they don't potentiate the Parkinson's symptoms. So the initial therapy that's used for people is levodopa, and that provides good motor control for about 4 to 6 years. But unfortunately, it does get less effective over time as more and more dopaminergic neurons are lost. Just giving more dopamine doesn't always help. So other things that we can use are things like dopamine agonists to potentiate the effect of the dopamine that's there already. They're called ropinirole and pramipexole, and they're normally given first in younger patients. They have less long-term side effects, and these are the ones that kind of you get the impulse control disorders in, so that when you hear about people with Parkinson's disease, like with new gambling habits and things like that, these drugs are the ones that are related to that. I've just missed the decarboxylase inhibitors section. So that's not a drug in its own right, but you give those in combination with levodopa to kind of prevent the peripheral breakdown of the drug. So you normally give co-beneldopa with that's the levodopa and the decarboxylase inhibitor together to kind of maximize its effect. And then the separate group of drugs is the dopamine agonists. Another group is the monoamine oxidase inhibitors, which inhibit monoamines oxidase, so they prevent dopamine breakdown. Adjuvant therapies are things like COMT inhibitors, so they also inhibit peripheral breakdown of levodopa and allow more dopamine to cross your blood-brain barrier. And then other things that you can use, things like procyclidine, amantadine can help with dyskinesia, and apomorphine you can use in advanced disease. These are kind of more specialist therapies. So the one to remember really is the levodopa, and that when it's given in combination with a decarboxylase inhibitor, it's the co-beneldopa or co-careldopa, and that's what's preventing breakdown in the peripheries. All these drugs come with side effects. So one of the main drugs has lots and lots of side effects, and there's a good way of remembering it on this picture there. So big side effects with levodopa are lethargy. Then you get like psychiatric symptoms, euphoria, you can get psychosis, vomiting, so you get the postural drop as well, or orthostatic hypertension. And then you get this thing called on-off phenomena, and that is like where people go from having dyskinesia to being immobile in minutes, and that's an on-off phenomena commonly seen with levodopa. Where it says dyskinesias, it can also cause things like dystonias, which is where excessive muscle contraction can lead to odd posturing or exaggerated movements. You can also get chorea, which is abnormal involuntary movements, the ones that you see in Huntington's disease. And then athetosis as well, which is involuntary twisting or writhing movements in the fingers, hands and feet. And those things can be side effects of levodopa. So the question also mentioned surgery. So thalamic or subthalamic surgery can be used in Parkinson's disease, and deep brain stimulation can as well. But those are also specialist managements, so we'll go into them. So question 3, just get the poll up for you. that working? There you go. So this question was about a lady with arthritis and a hernia and multiple myeloma who's got a history of new confusion, abdominal pain, nausea and constipation. So what would we use? Yes, well done everyone. You've all put B, which is correct. So A is incorrect, which doesn't report any dysuria. B is the correct answer because we want to know whether this lady has a high calcium or not, given her diagnosis of myeloma. A nuclear bone scan would not confirm that the diagnosis is hypercalcemia. It might show, so in myeloma, the osteoblastic response to bone destruction is kind of negligible. It doesn't often show up on the scan. It might show areas of reduced uptake, but it doesn't show kind of METs necessarily. So it wouldn't confirm a diagnosis of hypercalcemia, if you see what I'm saying. A CT scan might show those lytic bone lesions, but it's I don't think with the whole like bowel not opening for a week story is enough to convince a radiologist that this patient needs a CT scan. And doing a CT head, there's no suggestion of kind of new focal neurology or head trauma, so that wouldn't be indicated. So hypercalcemia of malignancy is what this question was about. It occurs in 10 to 20% of patients with cancer, and actually 40% of patients with myeloma get hypercalcemia. So it's really significant in people with cancer. And you get the classical symptoms, so the stones, bones, moans, thrones, muscle tone, and psychiatric overtones. This is quite a nice, like, thorough explanation of the symptoms associated with hypercalcemia. The mechanisms of hypercalcemia. So there's three main ones that cause it in malignancy. So the first mechanism is the most common one, like in 80% of cases. Cancers will produce this parathyroid hormone related peptide, and that acts like PTH, acts on the bones to increase resorption and blood calcium. So that's quite common in squamous cell lung cancer and renal cancer. That's the mechanism they use. Mechanism 2 is the one that's in multiple myeloma and leukemia. So the osteolytic bone lesions, because of osteoclast activation, leads to calcium in the bones, in the blood, sorry. And then the last mechanism is much more rare, but it increases your active vitamin D, the cancer, which means that your kidneys and your stomach resorb more calcium. So those are the three main mechanisms of hypercalcemia. And does anyone know, other than squamous cell lung cancer, renal cancer, myeloma, what other cancers are common to see hypercalcemia in? Yeah, so bone mets. CKD isn't a cancer, but you can get dysregulation of your calcium in CKD. Other cancers that you get hypercalcemia in are things like breast cancers, head and neck cancers, and prostate cancer as well. They're all associated with hypercalcemia. So in terms of management, if the calcium's less than 3, you kind of just want to rehydrate them. So IV fluids, or if it's really mild, you could just encourage oral fluids. You need to review their meds to avoid precipitants. So things like thiazide diuretics, lithium, and being dehydrated, they all need to be considered on whether or not they can stop them. If the calcium's more than 3 or the patient's symptomatic, then we need to resuscitate them with IV fluids. So these patients need at least 3 litres of fluid over 24 hours. That's when it gets quite tricky with patients who have quite bad heart failure or fluid overload who come in with this high calcium, because 3 litres in 24 hours is going to overload some patients. So you can consider adding furosemide in at the same time to enhance your urinary calcium excretion. But the main thing that we would need to do as F1s is just resuscitate the patient. And if you're concerned about overload, then seek senior advice. IV bisphosphonates can also be used, but they can take 2 to 4 days to have an effect on the calcium level. But they do have a prolonged effect on the calcium level, so they act for like 2 to 4 weeks. And if the hypercalcemia is really severe or refractory to the above treatment, then you can consider dialysis in some patients. Okay, question 4. what did you guys put for this one? So this was kind of a meds reconciliation polypharmacy question for someone at the end of their life who is felt to be in the last days of his life. We're prioritizing comfort care and we're withdrawing active treatment. So which meds should be stopped in this patient? Okay. So D is coming out as the one that you've all gone for, which is the right answer. Well done. So if we go through A, B, C, D, A is just like all of the meds. So A is saying we should stop all of this man's medications, which would probably be an inappropriate thing to do, given that he's on an antiepileptic, and one of them is an antiemetic. And antiemetics are part of the kind of anticipatory classic end of life meds. So there's no need to stop some of these meds. So A is incorrect. B is partially more, it's more correct than A, because at least in this one we're saying we'll continue C, the levetiracetam. We want to continue the antiepileptic, but it also it's common for people's blood pressure to fall at end of life, so we don't really want to continue the furosemide and the bisoprolol, and we also don't necessarily want to stop the insulin, so that one's incorrect. C, again, we're continuing the bisoprolol, and I think the blood pressure thing is important to consider. D is the correct answer because we want to continue the seizure prophylaxis. We need to consider how to manage this patient's insulin ongoing. Like, is the patient still eating and drinking? Has he been having hypos? We don't just want to stop it outright. And then F, we want to continue the cyclizine because it's an antiemetic. E, so is incorrect because we don't need to continue the metformin on this one. So this one's saying continue D, which we don't need to do. So de-prescribing in palliative care, most meds can and should be stopped at the end of life. So drugs that are preventative, so things like a statin, bone protection, anti-anginals, antiplatelets, lots of anticoagulants, VTE prophylaxis, antidepressants, anticholinergics, like those used for incontinence, drugs for BPH, eye drops. We can just simply stop most of those because lots of them are for kind of like future health harm prevention. So if we stop them at the end of life, it's not like we're increasing his risk of an MI by 50% if we stop his statin today, because he's in his last days of life. It's unlikely that it's offering him benefit anymore. Some meds need more careful consideration. So things like anticonvulsants, diabetic meds, steroids, and Parkinson's meds. We need to think about when is best to stop them or how to stop them. Do we need to taper them or do we just cut them out? Do these meds need a replacement? And what do we do when the oral route is lost at the end of life? So can we use patches or subcut routes for these medications? It's also important to think about things like PPIs. So sometimes PPIs are used for symptomatic abdominal pain, but they can generally be stopped at the end of life unless there's kind of a really recent history of a GI bleed, because you can manage that patient's pain with a different medication, i.e. morphine. Osteoporotic meds should also be stopped unless you're using them for hypercalcemia, which was like the question before, and the hypercalcemia is symptomatic, and it's a risk benefit balance. Something that lots of people struggle with, and I struggle with at work sometimes, is managing diabetes at the end of life. So this is all kind of taken from Diabetes UK, and it does vary on the patient's prognosis. So if the patient has kind of a 1-year prognosis, if you think this patient is likely to die in the next year, it's potentially worth considering relaxing their blood glucose targets, because over that time they're going to eat and drink less, they might lose weight, and their blood glucose might drop. And if we're giving them like quite a lot of insulin and quite a lot of oral hypoglycemics, we might precipitate hypo episodes, which would cause them to fall, and then they come to hospital, and also they're just not pleasant. So allowing a slightly higher blood glucose is more tolerable with people who are approaching the end of life. Also, yeah, weight loss as they get more frail might mean that we can even stop some medicines. If patients have a prognosis of months to weeks, then the main thing that we want to do here is control symptoms. So what is the minimum intervention that we need to do to control the patient's diabetes related symptoms, i.e. symptomatic hypos or symptomatic DKAs? So can we switch like multiple complex combination therapy regimens to just single therapy insulin? And then if this patient has days prognosis, then it is kind of dependent on their type of diabetes. So this is taken from Diabetes UK. If they have type 1 diabetes, they're at higher risk of going into DKA, which can be really unpleasant symptomatically. And at the end of your life, it's just not what you want. So you might continue kind of once daily insulin with a reduced dose if their oral intake is reduced, a significantly reduced dose if they've been having hypos. And you want to be checking these patients' blood glucose once a day, if appropriate. If it's causing the patient lots of distress, then treat symptomatically. Patients who have type 2 diabetes in their last days of life who are diet controlled or on tablets, just stop monitoring blood glucose, stop medications. Patients who have type 2 diabetes who are on combination therapy or insulin, then generally you stop the tablets and you think about stopping the insulin. So that decision is kind of dependent on whether the patient is still eating and drinking and if they've still had hypos. And then you might still think about doing once daily BM checks. So this is just a guide. I think trusts would have their own guidelines about it. But if there was a question on it, it would probably be something like a diet controlled patient, can you stop their metformin? Or showing that you know not to just stop someone's insulin outright at the end of life and that there's other factors to consider. Okay, question 5. So this question is about an old lady with vomiting, reduced oil intake and dysuria. Her OBS show that she's a bit tacky and she's got a temperature. She's on some drugs that might cause low sodium. And her examination is interesting. So she's got a prolonged cap refill time and her tongue is dry. She's got no JVP, but she does have a little bit of edema on her ankles. She's obviously not got an oxygen requirement, so any overload in her chest isn't significant really. Her abdomen is soft and she's got some tummy tenderness. Her blood tests show that her sodium is about 121, which is quite low, and her urea is a bit high as well, and she's got a bit of an AKI. So you guys have all mostly gone for D, which is the right answer. Well done. So just going through them. So a UTI here is not the cause of hyponatremia. There's other clues in the question as to what might be the cause. B, so she does have some evidence of mild fluid overload in her interstitial tissues around her ankles and a little bit on her chest. But intravascularly, the examination report tells us that she's intravascularly dry. So her blood pressure is a little bit low, she's a bit tachycardic, she's got dry mucous membranes. So actually this patient's probably quite dehydrated, especially given her history of vomiting, reduced oral intake and dysuria. She's also biochemically dry, so she's got a high urea and a high HB, and those two things are kind of clues. So her hyponatremia is likely hypovolemic hyponatremia. So C, holding the causatory meds might help as well, but it doesn't rehydrate the patient. So you need to hold those meds and give her fluids. Hypertonic saline is normally only indicated for sodiums less than like 119 or for ones with neurological complications. And you have to be obviously very cautious in correcting hyponatremia that you don't precipitate demyelination of the pons. So giving normal strength saline is more appropriate because you want to be cautious. So this can be quite complicated as well, hyponatremia. And so bear with me here and just ask if you need me to stop or re-explain anything, just put it in the chat. So generally your sodium level in your body is determined by your total body water level. So it's affected, your sodium is affected by things that affect your total body water, as well as things that affect your sodium level itself. So total body water is affected by thirst or IV fluids that we're giving a patient. or it's affected by your ADH system, i.e. your antidiuretic hormone system, which affects how much water we resorb in the kidney. And your sodium itself is affected by your renin-angiotensin system, or aldosterone, or diuretics, or your intake of salt. So that's kind of how you would assess a patient, is based on how their total body water is affecting their sodium level. So hypovolemia, causes of that are things like GI losses, like diarrhea and vomiting, and pancreatitis, skin losses, so fever and burns, drug losses, so some drugs, i.e. the diuretics, and salt wasting. Addison's causes hyponatremia, and sepsis does as well. So the way that Addison's causes hyponatremia is because Addison's is obviously primary adrenal insufficiency, and your adrenal gland is what makes your aldosterone steroid hormone. So aldosterone acts on your distal convoluted tubule and your collecting duct. It increases your sodium channels, so more sodium is pulled in, more potassium is weed out, and so it increases the kind of saltiness of your blood. If you have Addison's and you have primary adrenal insufficiency, you're not making the aldosterone, or you have less aldosterone, so less sodium is like pulled back in, so more sodium goes out in the wee, and more potassium is pulled in. So that's why in Addison's you get that classic low sodium, high potassium. Euvolemic hyponatremia is caused by things like SIADH, so syndrome of inappropriate ADH release, hypothyroid, or high water, low solute intake, so like anorexia nervosa, primary polydipsia. And then hypervolemic hyponatremia is like heart failure, liver failure, CKD, and nephrotic syndrome. So if you need to assess those patients' fluid statuses to know what the differentials are for their sodium level. Some features of low sodium might be things like nausea and vomiting, short-term memory loss, lethargy, and then when it gets really, really severe and patients getting proper neuro symptoms, it's things like headaches, irritability, confusion, weakness, low GCS, and that's when you need to think, does this patient need to go to ITU? SIADH, I just thought we'd briefly touch on that. So antidiuretic hormone is released, water is resorbed from your kidneys because it means antidiuretic, so it doesn't want you to dilute your urine, so it pulls more water in from your kidneys to increase your circulating total body water, so you end up with a dilutional hyponatremia. Some causes of SIADH are certain drugs, so carbamazepine, SSRIs, Cipro, and ecstasy, and patients with atypical Legionella pneumonias can also get an SIADH and so get a low sodium. Neuro symptoms, so things like infection, subarachnoid hemorrhages, hematomas, weird and wonderful things can cause SIADH, and so can cancer, so small cell lung cancers can cause SIADH. So investigating hyponatremia. So the key thing in the investigation of low sodium is whether or not this is a true low sodium. So osmolality will tell us this, your serum osmolality. Osmolality basically just means how salty or dilute something is. So osmolality is the concentration of a solute dissolved in a solution, in this case, the blood. So if your osmolality is high, you've got a high concentration of solutes. If your osmolality is low, you've got a low concentration of solutes. And that is the formula for kind of calculating osmolality of blood. Osmolality will determine basically where water goes. So if blood has a high osmolality, i.e. lots of solutes, then water will go from the cells into the blood. And if the blood has a low osmolality and so has lots of water in it, then water goes from the blood into the cells. So blood osmolality can kind of be a surrogate measure for your osmolality of your cells because it should be in equilibrium. So if we go through the various kind of options, so if you have low sodium and you have a low serum osmolality, so you have a low concentration of solutes, then that's a true hyponatremia. If you have a low sodium and a normal serum osmolality, then you have a pseudo hyponatremia, and that can be caused by things like having high lipids or high proteins. So it kind of confuses the analyzer. If you have high lipids and proteins, it incorrectly tells us that our sodium is low, but it's not. It's just that we have too many proteins or lipids, i.e. you have something like myeloma or hyperlipidemia. If you have a low sodium and a high osmolality, so a low sodium and you're quite dry, then it could be something like HHS. So that's hyperosmolar hyperglycemic state. So if you look at the equation, a high osmolality would mean that your glucose level is very high, and that's what's bringing up the osmolality. So if you have a low sodium, high osmolality, it's probably HHS. Low sodium, normal osmolality, it's not low sodium, it's just a pseudo hyponatremia because you've got lots of lipids and proteins. If you have a low sodium and a low serum osmolality, that is a true hyponatremia. And then you move on to assess their fluid status, because that's what's going to hint at the cause. So we go back to this slide. If you assess their fluid status, this gives us an idea of what the cause of the low sodium is. And then after you've assessed their fluid status and you've got an idea of what the cause is, you might want to do a urine sodium or a urine osmolality, because that will tell you if the kidneys are implicated in the cause. So if the urine sodium and osmolality is high, then you know the problem does relate to the kidneys, because there's insensible loss of sodium in the wee when in the body it's low. And if it's low sodium osmolality, you know the kidneys are working correctly because they're trying to retain as much sodium as they can because it's low in the body. I hope that makes some sort of sense. Let me know if you want me to go over it again. But essentially the 3 steps of investigating the cause of hyponatremia are to check the serum osmolality, establish if it's true, check the fluid status, guess at what the cause is, and check the urine sodium osmolality. So are the kidneys the cause of the hyponatremia? So can I explain the HHS thing again? Yes, I can. So HHS, this hyperosmolar hyperglycemic state, happens sometimes in type 2 diabetics. So instead of DKA, these patients, some old type 2 diabetic patients, can go into HHS where their glucose is really, really, really high. If your glucose is really, really high, you wee it out. So you have really like sugary urine. If you have lots of glucose in your wee, it makes water and sodium follow. So HHS makes you lose sodium in your urine. Having a low sodium and a high osmolality is quite suggestive of HHS. So the low sodium is being caused by the uncontrolled sugars. So you need to treat the diabetic emergency to correct the sodium level. Does that make any more sense? That's how the two are related. Just going on to the cause, treating the cause now. So this is really simple. So does the patient have a low sodium because they're dry? Then you rehydrate them. Does the patient have a low sodium because they have SIADH? Then we need to establish what the cause of SIADH is. So is it a drug? Is it an infection? Find the cancer? Just treat the cause of the SIADH and that will correct the sodium. Does the patient have a low sodium because they're hypothyroid? Give them thyroxine. Have they got a low intake of salt? Then maybe refer them to dietitians. Are they overloaded? We need to offload them. Have they got HHS? Do we need to put them on some kind of sliding scale? Great. Sorry, hyponatremia is a bit grim, and we can come back. Would you have high osmolality of urine in HHS? So high osmolality means a high concentration of solutes. So, and these patients would tend to be dehydrated. So I think, yes, you would have a high urine osmolality because it's like a high concentration of glucose and a high concentration of sodium in the urine. So yeah, that's correct. Question 6. And there's your poll. Well done. So you basically all put D, which is the right answer. And this one is kind of combined with 7. So does everyone want to put what they put for 7? Okay. Bit more mixed for this one, a bit of a split between B and D. Okay. So if we go back to 6, so everyone was right, it was new compulsive behaviours, is a classical feature of frontotemporal dementia. So A, the hallucinations are quite a common feature of Lewy body or delirium. Postural instability and frequent falls is a common feature of Parkinson's or Lewy body. Diabetes, multiple MIs is a feature of vascular dementia, and early impairment of memory is common in Alzheimer's. And then for this question, so this lady's been started on a medicine to treat her Alzheimer's that works by blocking the action of glutamate in the brain. So which drug is this? So you guys went for B and D. So the correct answer is B. A, rivastigmine is an acetylcholinesterase inhibitor. B, memantine is correct. It's an NMDA receptor antagonist, which means it blocks glutamate essentially. Risperidone is an antipsychotic, and D and E are both other examples of acetylcholinesterase inhibitors. So if we go over the different types of dementia, Alzheimer's is obviously the main one. 50 to 75% of cases are Alzheimer's related dementia. Commonly on a CT brain, you'll see medial temporal lobe atrophy, and its classical features are early short-term memory loss that progresses to global intellectual decline and then full dependence and the BPSD, so those behavioural and psychological symptoms of dementia. Those are things like wandering, restlessness, disinhibition, the repetitiveness, and then the psychological symptoms of like anxiety, depression, insomnia, and delusions. The next type is a vascular dementia. So this is also really common. Recurrent thromboembolic events and high blood pressure lead to infarct of our small vessels, and you get a classically stepwise decline in vascular dementia. Those early motor and emotional symptoms are more common than Alzheimer's dementia, and then you get that later memory impairment with vascular dementia. Lewy body dementia is about 10% of dementia cases, and you get more cognitive and Parkinsonian symptoms. So the way to tell the difference between Parkinson's disease related dementia and then Lewy body dementia is that in Parkinson's disease, the dementia will start more than 12 months after the Parkinson's symptoms started. In Lewy body dementia, the Parkinson's symptoms and the dementia start within a year of each other. So with this one, you get early impairment of attention and executive function, you get hallucinations and REM sleep disorders. Frontotemporal dementia. So it's quite rare generally in the group of dementias, but actually it accounts for 20% of early onset cases. So people under 65 who get dementia, 20% of these are frontotemporal. Initially, it's commonly mistaken for a psychiatric disorder because it has quite a lot of behavioural symptoms associated with it. So disinhibition, loss of empathy, and things like compulsive behaviours that are new for the patient. But there's other forms of frontotemporal dementia that are primarily associated with language dysfunction. So primary progressive aphasia is a different type of frontotemporal dementia. And then you have your rarer causes, so AIDS-related or end-stage HIV-related dementia, and then CJD, which is a prion disease. Huntington's and Parkinson's disease also can cause dementia. In managing the different types, it varies based on the type of dementia. So in Alzheimer's, we use your acetylcholinesterase inhibitors, our NMDA receptor antagonists, like memantine, and antipsychotics. Memantine is generally preserved for kind of more severe cases further down the line. Donepezil would normally be kind of, if you were going to medicate someone with dementia, donepezil would be a common one to start. You can also use antipsychotics like haloperidol and risperidone as a last line for managing BPSD after environmental modifications or in people who are prone to a delirium. Donepezil can cause things like insomnia, and memantine can cause constipation, so they're just common side effects to remember. In vascular dementia, generally we just have to aim to modify people's risk factors, so we might consider anticoagulating them, preventing further thromboembolic events, managing their blood pressure and things like that. If it was a mixed dementia, we might consider starting donepezil, i.e. mixed Alzheimer's and vascular dementia. Lewy body dementia, so you can again use things like donepezil and memantine, but we would avoid antipsychotics in people with this condition because that can worsen the Parkinsonian symptoms. Frontotemporal dementia, you can use SSRIs, which might improve people's disinhibition because of the side effect of loss of libido, but generally you have to just treat the symptoms. Where you're advised to avoid acetylcholinesterase inhibitors in frontotemporal dementia, so you're more limited in terms of what you can use. And then the rarer conditions are generally treated by treating the condition and using antipsychotics and antidepressants. Okay, question 8. We're getting there, guys. So this question was about a man who came in with a fall. He's got a long history of prostate cancer, a bit of constipation, some low back pain. What would we do to investigate this man's constipation? Fab. So most of you have said D, which is the right answer. So the question asks for the next step with regards to investigating this man's condition. So nuclear bone imaging, it might show things like bony or spinal mets, but it can't confirm or rule out a metastatic cord compression, which is what this question is trying to get at. An MRI whole spine, without a neuro exam, it's uncertain whether this exam is indicated or not. It's quite a kind of long scan, and if someone doesn't need it, then they'd rather not do it and save the MRI machine for someone who does need it. So you'd need to have done a neuro exam and a PER before requesting an MRI whole spine. A CT abdo-pelvis with contrast. This patient hasn't opened their bowels in 10 days, but they have got a soft tummy with bowel sounds. So it makes kind of obstruction less likely, especially with no history of vomiting or severe abdominal pain. But it's something to consider, probably more related to the cord compression that we're worrying about. It adds to that picture. So D is the correct answer. Blood calcium level, it's possible that this man might have hypocalcemia, but it's less acute than metastatic spinal cord compression. So this needs to be assessed for first, but it's something that you would think about as well. So MSCC, 3 to 5% of cancer patients have spinal mets, and it's the most common neurological complication of cancer. 70% of cases are in the thoracic spine, but it does also occur in the lumbar spine. And the common cancers that it is caused by are things like lung, prostate, breast, myeloma, meningiomas and gliomas as well, because they can compress on the spinal cord directly. Symptoms, so classically you get back pain, limb weakness, difficulty walking. Sometimes people describe it as walking on cotton wool. And then the kind of urinary bowel symptoms might start off more insidious, so a bit of hesitancy or a bit of constipation, and then progress to full-on urinary retention, and then progress after that to complete incontinence, so loss of control of bowel and bladder. You also get that saddle anesthesia, so you can't feel the tissue when they're wiping after going to the toilet, things like that, and some other neuro signs. Managing MSCC, if someone has a known cancer, you have a very low threshold for an urgent MRI whole spine within 24 hours. And then you'd start them at the same time, probably on 16 milligrams of oral dex a day. You need to bear in mind with this that people should be started on a PPI and monitor their sugars, because it's obviously irritable to the stomach. In terms of managing confirmed MSCC, you can think about surgery if there's a single area of collapse, if someone's got a good prognosis or performance status. But if someone's been paraplegic for more than 48 hours, it's unlikely, or they've got structural failure of their spine, surgery isn't likely to be indicated. Radiotherapy single fraction is probably more likely the route that you'd go down definitively. It's really, really bad, obviously. 70% of patients who present with MSCC have died within a year. So it's not a great prognosis going forward. Question 9. Let's start the poll. Oh, sorry, I don't think I shared your results for the last one. There you go. Sorry, just bear with. Question 9. So this is a question kind of about opiate management in palliative care. So this is a guy with lung cancer, progressive lung cancer who's deteriorating, and we're taking a palliative approach to his care. The patient can't take his meds orally, so we need to prescribe a driver. He's currently taking 30 milligrams of oxycodone twice a day. He has required 3 breakthrough doses of 10 milligrams of oxycodone in the last 24 hours. Which of the following represents the correct syringe driver dose? So, bit mixed. People have gone for A, B, and C. No one's interested in D and E, which is good because they're wrong. But the correct answer is B. So the reason for that is this man is taking 30 milligrams of oxycodone twice a day. So regularly he's taking 60 milligrams of oxycodone twice a day. He's also taken 30 milligrams of oxycodone PRN. So his total dose in 24 hours is 90 milligrams. We're being asked to prescribe a syringe driver dose for this patient, and a syringe driver is given subcutaneously, and the strength of oxycodone is double subcut than it is orally. How did I get to 90 milligrams? So I'm just going to type it out. So he's on 30 milligrams BD, which is 60, and he's also taken 30 milligrams PRN. So 60 add 30 is 90 milligrams total in 24 hours. And then in the driver, the strength is double. So when you convert oral oxycodone to subcut oxycodone, you divide by 2. So the dose in his driver should be 45 milligrams. And then we need to calculate his PRN dose based on his total 24-hour dose. And the way that we do that is the PRN dose is 1/6 of the total daily dose. So he's going to take 45 milligrams a day over 24 hours. So we divide it by 6, and the answer to that is 7.5 milligrams. Does that make sense? So the reason that A isn't correct is because it doesn't account, the driver dose doesn't account for adding in this man's PRN doses. So what this has done is just say he takes 60 BD regularly. He takes 60 over 24 hours regularly. So 60 divided by 2 is 30. But actually he's needing 3 breakthrough doses in 24 hours. So we just add that into the driver. So he's not having to ask for as many doses. So B is correct. C doesn't account for oxycodone being twice as strong in a driver as it is orally. So they just haven't divided by 2. And then D is calculated as though oxycodone is 2 times less strong subcutaneously than it is orally. And then E is just wrong. Okay, so this is an opiate conversion chart. It's good to kind of commit some of the basic ones, the oxycodone and the morphine ones, to memory just for your exam. So oral morphine converting to subcut morphine is just divide by 2 or times by 2 to convert back. Oxycodone is twice as strong as morphine. So oral oxycodone is twice as strong as morphine. And then oral morphine is subcutaneous oxy is 4 times as strong as oral morphine. So just remember those. I think those 3 would probably be enough to remember. I don't think that you'll be asked to kind of calculate transdermal fentanyl conversions without being given the conversion number in the exam. Just a quick bit on analgesia and renal failure. So general rules: if a patient has a low EGFR, then you need to generally use immediate release medications rather than slow release meds. Reducing doses obviously and increasing dosage intervals, so maybe giving it like kind of 6 hourly instead of 4 hourly can help with the patient has poor renal function. Generally you totally avoid NSAIDs unless someone's is honestly just in their last days of life and the only thing that's getting on top of their pain is an NSAID. Then in that case the benefits might outweigh the risks, but you'd want to discuss with palliative care, and you'd try and avoid codeine in people with poor renal function. Tramadol is something that you can use, you just dose reduce. And then in terms of the strong opioids, I've kind of written out the order of preference. So morphine is less preferable than oxycodone. Oxycodone is kind of reduced less renally than morphine is. Morphine is excreted renally. So if you give fairly whacking doses of morphine to people with poor renal function, you're just going to push them into toxicity. And then hydromorphone is better than oxycodone. Fentanyl, buprenorphine, alfentanil are all better than the rest if someone has really, really poor renal function. They're the ones to use. In palliative care, you can also use different pain adjuncts, so things like amitriptyline, gabapentin, pregabalin. benzos, and as I said, NSAIDs in some cases. Sometimes we use steroids for pain, and then radiotherapy, hot and cold, TENS, acupuncture and relaxation. They're all important things to consider if you're being holistic about managing someone's pain. Okay, question 10. So this question was about what to write on a death certificate. It's a bit of a shame. So this man was sat in hospital, medically fit after coming in with a fall. CT head was normal, just waiting for a package of care to be set up at home. But because that was taking so long, he ended up getting a HAP and he died. His background is significant for prostate cancer, IPF, and type 2 diabetes and dementia. So which of the following should be written on this man's death certificate? You guys have gone for D, which is right. Well done. So the reason that A was wrong is because we've written respiratory arrest in 1A, and respiratory arrest is a patient's mode of death. It's not a cause of death. And we've written also idiopathic pulmonary fibrosis as 2, and that the pulmonary fibrosis probably didn't contribute separately, but was more likely to predispose him to getting a HAP. So it kind of makes it 1B rather than 2. So answer B, again, we've put respiratory arrest as a mode of death. C, we've written interstitial lung disease, which isn't very specific, and it might suggest actually the need for a coroner's referral, because ILD can be asbestos related, and then we need to refer to a coroner. So you need to be specific about the disease process that we're referring to. And then also it's kind of suggesting that the cancer led to the interstitial lung disease, which led to the HAP, so it's a bit confusing. D is the correct answer, and then E, we've written interstitial lung disease again, and there's no mention of his diabetes on here. So for a death certificate, you must have cared for the patient alive to be able to complete it, and you must know their cause of death, and so that you know if a coroner's referral is needed. Part 1 is what caused the death. So 1A is what directly led to this person's death. So for this man, what directly led to his death was a hospital-acquired pneumonia. 1B is something that may have led to 1A. So his idiopathic pulmonary fibrosis led to 1A. It's kind of like if someone had an unsafe swallow because maybe they'd had a previous stroke and then they died of an aspiration pneumonia, that previous left NCA infarct would be 1B and the aspiration pneumonia would be 1A, because the two things are interlinked. And then 1C, sometimes there's things that led to the thing in 1B, so you don't have to put a secondary cause if there isn't one, but they're just optional. And then part 2 is any other significant condition that contributed to the death but was not related to the disease or condition that caused the death. So in this man, his metastatic cancer is probably relevant to his frailty, and his type 2 diabetes put him at increased risk of developing an infection. So those things would have contributed to his death. Phrases to avoid on death certificate. So like I've said, don't write the mode of death. So don't write arrest or failures or shock. You've got to write what led to the arrest or the organ failure or the shock. Generally, you avoid things like old age or frailty of old age, and you never use abbreviations or symbols. You can't write things like asphyxia, cachexia, coma, exhaustion, or natural causes. It all has to be specific. If we were going to refer to a coroner, does anyone know any indications of when we might refer to a coroner that they want to put in the chat? There are loads. No worries. Suspicion of neglect. Yeah, that's a good one. There's tons. So if we felt someone's death was unnatural, or their cause of death was unknown, or the death might have been due to neglect, like or self-harm, or violence or trauma. So say if this man in our question had come in with a fall and a head injury, and his CT head had shown a massive bleed, and then he died of that bleed, that death would have had to go to the coroner's court. Yeah, so there's a big old list. The Geeky Medics have a really good list of coroners, when to refer to the coroner's court. So I would advise that you look at that, especially if you've got an OSCE coming up, because that's something that they could ask you about. Question 11. So this one is about a lady who has dementia with Lewy body, who's come in with urinary retention. She's been catheterized, commenced on treatment for a UTI. She's become increasingly distressed. Her family report that this is not normal behaviour for her. She's aggressive and violent with staff and is felt to pose an ongoing risk to patients. De-escalation attempts are tried and the patient is placed under a DOLS. Her behaviours will get worse. So what do we do acutely? Let's see what you guys have said. So yeah, mix of D and E. I'll show you them. There you go. So for this question, E was a correct answer. So A, requesting a dementia specialist review for consideration of donepezil is not an acute action. The problem is actually her delirium, secondary to being in retention and having a UTI, being in an unfamiliar environment. She's got lots and lots of risk factors for a delirium. So having a dementia specialist review probably wouldn't be helpful, especially in the acute situation. Requesting a CT head. So this lady, in the question, there's no suggestion of focal neurology and there's no suggestion of head trauma. So it's not the most correct answer in this question. In an actual real life situation, you might think if this lady came in with no collateral history and had a raging delirium, you might think, has she had an unwitnessed fall at home? But I think in the acute situation, requesting a CT head isn't going to be helping manage her behaviours, and it actually doesn't sound like she's well enough to go for a CT. It doesn't sound like she'd tolerate the scan right now. Escalating her antibiotic therapy. So there's no suggestion of worsened infection, and she's likely already on antibiotics for her urine infection, and it wouldn't change her her kind of behaviours acutely. So in this instance, this question is about rapid tranquilization. So it's a question of, does this patient need IM haloperidol or oral lorazepam? IM is more invasive than oral lorazepam, and dementia with Lewy body is a contraindication to giving haloperidol. So E is the correct answer in this situation. E is more correct than D, because you always want to start by offering the patient a tablet that might help their behavior and calm them down, rather than going in there and injecting intramuscularly. So delirium is an acute confusional state that causes disturbed consciousness, attention, perception, and cognition. The classical things about delirium that distinguish it from other confused states are that it is fluctuating and it comes on acutely, and that there's generally evidence of an organic cause. I don't think many people know this, but it's actually considered by quite a lot of acute medics to be like a medical emergency, because patients who present with a delirium have a 70% risk of dying in the 6 months after they present. So that's most of them die. And I don't know if we always consider that when we're seeing someone with a delirium. Then the main risk factors for it are kind of advancing age, having lots of comorbidities, having a background of dementia or cognitive impairment, pain, alcohol excess, a sensory impairment, being malnourished. All of those things make someone more at risk of having a delirium. And there's the classic pinch me mnemonic that will help you kind of identify potential causes. Generally, it's multifactorial, just as a heads up. So rapid tranquilization. The things that we need to think about if we're getting to the stage where the patient is a risk to themselves and a risk to other people, the first thing that we need to do is a capacity assessment. So does this patient have capacity at the moment? Is there a need to put this patient under a DOLS? Because if we're going to give someone medication to sedate them, then the patient needs to be under a DOLS. Then we treat the underlying cause. So we need to be either giving them laxatives, antibiotics. A common cause of someone being delirious on a ward acutely is they've just suddenly gone into urinary retention. So just have a feel of their tummy, make sure that you're looking at the medicines and there's nothing that we're giving them that's making it any worse. Then you want to try and de-escalate the situation. So putting the patient in a low stimulation environment, calling their family, seeing if their family can come in, getting them their glasses, hearing aids, putting a clock in their line of sight, and then keeping them safe. So one-to-one nursing, preventing falls, promoting them going to sleep. Those are all things that you want to be trying first to manage the patient. And then rapid tranquilization is your last line. So you want to use the lowest possible dose. All is preferred over IM, and then kind of 0.5 mg of haloperidol or 0.5 mg of lorazepam. There's often trust guidelines for rapid tranquilization, and documentation in this scenario is really important to make sure that medically legally you're demonstrating that you're considering, does this patient have capacity? Have we tried everything else first? Sometimes you might get a call when you're in F1 kind of late at night about a confused patient who's agitated and the nurse is struggling to manage, who want you to write up PRN lorazepam so that they can give it whenever. I just don't feel like having it on the drug chart all the time is always the best option for the managing the behavior. It can sometimes be a temptation, and obviously these medicines don't come without risks. These are old, frail people who might get a delirium and could have high risk of falls. So I would always just prescribe it as a stat dose, and if you need to go back and prescribe another dose, then you can do that, but at least everyone's safe. Okay, question 12. So this is a really old lady. She's 96. She's in her last days of life. She's on comfort care pathway. She's unresponsive and sleeping all day. She's very comfortable and in no stress. But she's got lots of secretions despite being on a very high dose of hyoscine. What do we do now to manage her secretions? Lovely. Most of you have said C, which is the right answer. So A, increasing the hyoscine. She's already on 120 milligrams over 24 hours, which is quite a high dose. Increasing that dose is likely to just lead to side effects, and the patient herself is very comfortable and in no distress and sleeping all the time. So there's no need to medicate her. Suctioning her upper airway. This lady is sleeping and comfortable, and shoving a big suction catheter in her mouth is likely to cause distress. Gentle suction of the upper airways. Sometimes people might say that's appropriate if there's nothing else we can do, and it's obviously causing the patient distress. But like putting a big suction catheter down might just cause trauma. They might bleed, uncomfortable in their mouth. I think I'd just leave it alone. Reassuring the family is the correct answer, because it clearly states the patient's comfortable and the issue is with the family's anxiety. So reassuring that the patient is so comfortable that they don't even want to clear their secretions, and that they're just letting them sit there and they're not bothering them at all is the right thing to do. Putting the patient on a saline neb again might just distress the patient. At this point, she's likely too weak to clear any secretions that we loosen up anyway, so they'll all just sit there. And oral amoxicillin, so this lady is on comfort care. We're not giving her active treatment, whether she had an infection or not. So just reassuring the family in this instance. So most patients at the end of life will have some secretions. It's more common in patients who have lung or brain cancers. And the main issue with it is that it's unpleasant for us, really. Discussing with the family, explaining that it's because the patient's so comfortable that they aren't aware that they need to clear their throat. Repositioning the patient can often be more than enough. Just tilting the head to one side or the other, placing a pillow under a different area can often drain the secretions out of one side of the mouth, and doing really good mouth care as well. Giving an anti-secretory is fine, but increasing the dose past 120 milligrams in 24 hours is probably just better to reassure. Okay, question 13. So this question is about a lady with a medication side effect. So she's come in, she's had some bloods, everything's fine, but she's got a slightly low calcium. Which one is causing the low calcium? Okay, so there's a bit of a mix between the thiazide diuretic and the alendronic acid. So the answer here is actually alendronic acid. Prednisolone doesn't cause a low calcium. Benzofumethiazide can actually cause a high calcium. Tamoxifen can also cause a high calcium. Alendronic acid causes low calcium, and citalopram doesn't have any effect on calcium. So this question was kind of about side effects of osteoporosis treatment. So osteoporosis is essentially an imbalance of bone breakdown and bone formation. So as we age, our osteoclast activity out kind of exceeds the osteoblast activity. So we're losing bone more than we're making bone. If you have an estrogen deficiency when you're postmenopausal, that will increase your rate of bone loss. And if you're on steroids and things when you get older, that will increase your turnover of bone. So some risk factors are things like being female, having a vitamin D deficiency, being on steroids, having previous rigidity fractures, age, a low BMI, drinking lots of alcohol. They're all risk factors for osteoporosis. And the key number to remember is that your T-score on a DEXA scan is less than 2.5. Having a T-score less than minus 2.5 on a DEXA scan is diagnostic for osteoporosis. The meds that we use are bisphosphonates. Sometimes we use denosumab, and sometimes we use selective estrogen receptor modulators. You can also use things like HRT and dietary modifications. Bisphosphonates have loads and loads and loads of side effects. So things like esophagitis and gastritis, and even duodenal and gastric ulcers, dysphagia, GI discomfort, low calcium, like in this question, and then weird things like atypical femoral fractures and osteonecrosis of the jaw. Osteonecrosis of the jaw is this really rare, weird condition where a part of your jawbone starts poking through your gum, and then the area that's exposed doesn't receive any blood, which means that the bone dies. So that's quite a serious side effect. So that's why when people are going to be started on a bisphosphonate, it's important to do a bit of a dental exam first. Denosumab is a different drug that can also cause hypocalcemia and can put people at increased risk of getting cellulitis. And then the selective estrogen receptor modulator, they can cause leg cramps, VTE, and increase your risk of stroke. Cool, we're getting there. So question 14, nice little derm question. Let's see if we can share. So this lady has a mark on her cheek. What do we reckon it is? We're all given up. No one's answering. Does the poll come up? Is it working? Oh, it disappeared. Sorry, my fault. I'll try again. Oh. Relaunch. There you go. Is that working now? Nice. Everyone's gone for a BCC, which is right. So A, squamous cell carcinoma. These are classically crusty, nodular, indurated lesions. Sometimes they have like a central mass of keratin as well. They can also be kind of described as verrucous, and they can arise in chronic wounds, and it also involve your nail bed as well. A BCC, which is what this is, has classical features of telangiectasia, which this lady has, little red vessels on it, pearly rolled edges, ulceration. So that's what this is. Sebaceous hyperplasia. Generally, you have more than one of these, and they don't have any ulceration. They're just small yellow bumps up to 3 millimeters under the skin. This is probably a bit too big to be a sebaceous hyperplasia. Molluscum, they're like pearly small lumps with a central umbilication. They're clustered, and they're normally an infection seen in children. And then actinic keratosis is a flat, thickened papule, can be white, yellow, scaly, warty. I've just done for this one a couple of pictures of different dermatology conditions in the elderly, just to go through. So some benign ones. I don't know how you want to do it. Do you want me to like put the picture up and then you can say what you think it is? We could try that way. So what do people think this is an example of? Yeah, I guess it kind of does look a bit like henified. A bit like unisex, maybe. It's even more simple than that. So this is just a picture to kind of try and show xeroderma, which is just a fancy way of saying dry skin. So when people get older, they lose more water through their skin, it gets thinner, and it's dry. Everyone on inpatient wards has dry legs, on the elderly wards. So it increases their risk of getting skin breaks and cellulitis. It's itchy, it's prone to dermatitis. So I guess in a way it is a form of eczema. and it's really common on old people's legs. How about this one? Okay, no takers for this one. This probably with the erythema, swelling, edematous, yeah, it's kind of associated with venous stasis or venous insufficiency. So they're chronic changes on the lower legs consistent with venous insufficiency. So it's swollen, it's dry, it's discolored and cracked. If that was hot, it might cross your mind that it could be a cellulitis. But I've given you a clue by saying it's benign. And so it's quite common to see chronic skin changes with venous insufficiency. How about this one? Rosacea, yeah, exactly. Well done. Rosacea is more common in women. It's red, it can be, and it can sting. Some people have triggers, so sunshine, drinking alcohol can trigger their rosacea to flare up. It's more common in older people. Does anyone know what these little marks are on the back of this person's hand? SEBK. So yeah, seborrheic keratosis are really varied presentations, so I can see why you've said that. This is actually just an example of a solar lentigo. Loads and loads of old people get these. These are just harmless areas of darkened skin due to UV exposure. Seborrheic keratosis is a harmless warty spot, and they're also a sign of skin aging. So there's subtle differences between the two. Solar lentigos are generally flat and you can't really feel them. And then a seborrheic keratosis, you'd be able to feel just running your hand over it. So these are all pictures of SEBK. So that and that, they're all the same thing. Okay. Some malignant conditions. So these two are the same thing. Does anyone know what they are? Just straight up. SCC. Almost. Yeah, it's an actinic keratosis. So they're a precancerous spot on sun-exposed skin. They're kind of like an early cutaneous SCC. Yeah. And then these two are the same thing as well. This is a bit harder. So those two are an example of a Bowen's disease. So that's an example of an intradermal squamous cell skin cancer or an early SCC, and they can happen to the nails and just form like an erythematous scaly plaque. And then this one, oh, anyone know what that is? Basal cell, yeah, exactly. So the pearly edges, the rolled borders and the ulceration. And then that one, what's that look like? Keratocanthoma. Yeah, it's got a lot of keratin on it, doesn't it? That's actually an SCC. But I think when you get into like more niche ones, they're much more harder to distinguish, especially when there's a central mass of keratin. So I can see we've said that. But generally SCCs are irregular keratinous nodules. They ulcerate, they're faster growing, and they can kind of pop up anywhere. And then what's this one? Sorry, that's a rubbish picture. Melanoma. Yeah, exactly. And then this is the last slide. So infectious conditions in the elderly. What's that one? Yeah, shingles. So a painful vesicular rash confined to one dermatome, classic shingles. This one, what's this an example of? Cellulitis, yeah. So you can see it's erythematous. The skin looks really shiny, which is suggesting that it's quite stretched and swollen. And then there's like a vesicular blister. It looks really nasty, pussy on the bottom of the leg. So that looks like a nasty cellulitis. And then what are these examples of? Sorry, it's a bit grim for a Thursday night. Yeah, pressure sores. So older people who lie in beds on wards for a long time and aren't very mobile are high risk of getting pressure sores. So the nurses are really good at keeping an eye on the really common pressure areas. when they get to kind of stage 3, stage 4, you're much higher risk of getting an osteomyelitis. Often you can even get to the point of having exposed bone with pressure sores. So it's important to keep a close eye and be preventative about the development of them. Okay, last one. We can do this. So this question was about a lady, what have I done? A lady with a brain tumour who has just completed a course of palliative chemo, and she's come in with a seizure at home. What's the best thing to do, first lady? Okay, it's quite hard. We're all very mixed. A couple of you've gone for A, a couple of you've gone for D. So the right answer here is actually B. Okay, so A, monitoring for further seizures and starting an antiepileptic if they recur. In a lady with a brain tumour that we're kind of treating palliatively, you generally treat them after their first fit because she's at very high risk of having a recurrence. So you generally treat with an antiepileptic after the first fit if someone has known brain cancer. So B is the correct answer. C, prescribe regular midazolam. So in this lady, who we haven't really got much context, but she doesn't sound like she's on her last legs. She's still at home. She's just gone through a course of palliative chemo and radiotherapy, which you wouldn't do if somebody had absolutely no reserve. So with midazolam, you'd probably use it as seizure control when the oral route is lost, and you could give it through a driver. But in the meantime, using an antiepileptic is a better way to go. Prescribing lifelong dex. So dexamethasone you can use in brain cancers, but you only ever generally use it as a course. You normally taper it off. So if someone comes in with symptomatic raised intracranial pressure or symptomatic of seizure because of raised intracranial pressure, you would give them a high dose of dex for about 7 days, but then you would wean them off the dex. Because of the side effects of the steroids, you only ever give dex in a course. We don't know anything about this lady's prognosis, how long she's got left. So we wouldn't give lifelong dexamethasone. You just give it as a course. And then E, refer to neurosurgery for consideration of tumour debulking. So this lady's just had palliative chemo and radiotherapy. Referring for debulking surgery is likely a consideration that's been had earlier in her disease course. So if she was going to be able to have surgery, she's probably already had it prior to this. So seizures at the end of life. Causes of them, so most commonly they're due to primary or metastatic brain tumours, infections, hepatic encephalopathy, hypoglycemia, drug withdrawal, strokes, or pre-existing epilepsy. And seizures due to brain tumours. So for these ones, we diagnose epilepsy after the first seizure. We consider surgery, radiotherapy, chemotherapy on a patient-by-patient basis. And if they're viable options, then part of their aim would be to make the patient seizure-free. You'd start an antiepileptic after the first fit if they were a high risk of recurrence, and you don't give them prophylactically. So if someone's not had a seizure, you wouldn't give them levetiracetam just to prevent them if they ever did have one. You only give it after they've had their first fit. And you also need to make sure that the patient stops driving if they're still doing so at that time. When we lose the oral route for seizures at the end of life, there are different options that you can consider. So you can use PRN, subcut midaz, or buccal midazolam. But generally, I think what's safer if people are having active seizures is to put midazolam in the driver at a higher dose. You can also put levetiracetam in a driver. It's a 1-to-1 conversion. So that's another option. There are lots of palliative care emergencies. So we've talked about seizures, we've talked about hypercalcemia, we've talked about metastatic cord compression. Another one is major hemorrhage. So you need to, for this, if someone's got a cancer that is at risk of having a major hemorrhage, anticipatory planning is really key. So having on the drug chart a PRN prescription for high dose of midazolam, making sure that a DNA CPR is in place, and having kind of dark towels, discussing with the patient what they would want if they had a massive bleed. If that bleed doesn't look like it's survivable, then giving someone midazolam is a kind thing to do to kind of prevent the distress at the end. Superior vena cava obstruction is obstruction to the SVC by external compression or like direct invasion from a cancer. So some key symptoms of SVC are like breathlessness, visual changes, swelling of your face, neck and arms, headaches, and things like that. The classic Pemberton sign is where they put their arms over their head and they get lots of facial flushing. If you're actively treating someone with superior vena cava obstruction, then you want to be giving them oxygen and 60 milligrams of Dex, like you would with MSCC, and then they'd be considered for vascular stenting or angioplasty or radiotherapy. If you think that's not appropriate and this patient is palliative, then kind of treating them symptomatically, so loose clothing, helping with them with their breathlessness with midazolam and opioids, and encouraging airflow through the room can help. Tumor lysis syndrome. So it's a bit of a rogue one to add in at the end, but it's kind of just a combination of metabolic and electrolyte abnormalities occurring following chemotherapy treatment in patient with cancer. So it's more common in cancers that are highly proliferative, so things like lymphomas and leukemias. And it causes high uric acid, high phosphate, high potassium, and a low calcium. So to prevent that from happening, you generally hydrate patients and give them allopurinol when they're having their chemo. And if you're actively treating someone with tumor lysis syndrome, then you need to treat things like the arrhythmias with calcium gluconate. You should give them fluids. You can give them something called rasburicase, which encourages it like reduces the uric acid level. And you can also consider dialysis. But if someone's palliative and at the end of their life, then symptomatic management. Cool. So those are my references for the pictures that I popped in. There's another QR code for the feedback form. Does anyone have any questions about any of that I might be able to answer? I'm sorry, oh my God, it's 10 to 9. Wow, well done. That's taking my tea. Any questions, anyone? Is there any way to access the recording? Yeah, you'll get emailed the recording if you fill in the feedback form. I can send the link again. Thanks, everyone. Good luck with your finals. Hope everything goes well. Bye.